إن صباح الخير، كل سنة وانتم طيبين. رمضان كريم. النهاردة أول كونفرنس إن شاء الله في رمضان، وبعد فترة توقف بسبب المؤتمر وبسبب الأكتيفيتيز التانية هيكلمنا الدكتور أحمد عادل على حال إن شاء الله تبقى حاجة كويسة. اتفضل يا أحمد.
صباح الخير. كل سنة وحضراتكم طيبين. أنا أحمد عادل، مدرس مساعد في اسم القلب. Let's start our presentation with discussing the patient's history. Our patient today is a female patient, 39 years old, from Cairo. She presented with progressive exertional dyspnea. Her past history is significant only for intellectual disability. She's of average height and weight with no specific complexions and vitally stable. Her examination showed no remarkable findings. She was presented for our echo lab. She had only one echo with pulmonary stenosis. That's not significant, moderate pulmonary stenosis. That's what.
أنا بسأل على أساس إن اللي عندهم intellectual disability بيبقى عندهم حاجة غالبا
Usually metabolic أو حاجة.
بالظبط، فبيعملوا ايكو كاروتين تشيك اب during child period يعني.
ما هي she had a previous echo with, showing pulmonary stenosis, but she's not diagnosed with a specific metabolic disorder or any specific disease.
اوكي، يعني هي ما كانتش متشخصه حاجه معينه.
لا.
والايكو القديم بالمونري ستينوز ما عملتش اي انترفنشن.
moderate، مش حاجة significant.
وما عملتش اي
لا.
انترفنشن.
She didn't do any procedures before. So we started our echo with the subcostal view. Right from the start, we noticed that there is no IVC. In this view, we have the liver on the right side, what seems to be the gastric bubble on the left side, and we have the aorta to the left of the vertebrae. This is the vertebrae, and this is the liver. The liver is to the right side, and this seems to be the gastric bubble. And here is the aorta. It's the pulsatile structure to the left of the vertebrae. But what we seem to be missing is an IVC. It should be a circular structure to the right of the vertebrae.
سؤال معلش، يعني عيانه 39 سنه وانت ما عندكش هيستوري ان هي كونجنتال، ليه بدات سب كوستال؟
Because of the history of the pulmonary stenosis.
يعني هيستوري بالمونري ستينوز هو ده اللي ابتداك خلاك تبتدي سيكونشال اناليسيز من السب كوستال، which is seen هنا ان الليفر تو ذا رايت سايد ده نورمال.
Fasciitis. This is fasciitis.
بالظبط كده، والجاستريك بابل تو ذا ليفت، فاحنا كده ماشيين نورمال. اللي فاضل ان انت مش لاقي الاي في سي.
بالظبط كده. Here we can see the right atrium to the left of the screen, and we can see the hepatic veins opening into the right atrium. However, we cannot see a definite IVC. The IVC should be in the center of the liver, continuous. These are all the hepatic veins. Here we try to assess the interatrial septum. It appears to be intact, and this is the superior vena cava opening into the right atrium, and the hepatic veins, there's no IVC. So we moved on to the apical four-chamber view. Right from the start, we could see that there's a structure related to the mitral valve. We can see that the LV dimensions may be a bit dilated. We followed this structure. It seems to be a dilated coronary sinus. With the posterior angulation, it opens into the right atrium. This is the color flow of the coronary sinus. And we continued our assessment for the mitral valve apparatus. There's only a mild mitral regurgitation. And she had an impairment of the diastolic function. Okay, the E over A was 3.7. This donates an impaired diastolic function. The E prime, the lateral E prime was 14 centimeter per second. This seems to be a normal measurement. However, the septal E prime was 8, and the E over E septal, E over E prime was 15. This gives us a diastolic dysfunction. It's grade 2 to 3.
بتاعت الاي ريشيو، لو العيانه مش تاكيكارديك وما عندهاش سيفير مايترال ريجورج فانت كده مش 2 تو 3، انت كده جريد 3.
3 بالظبط.
في كومنت بس ان انت اللي قايسه في اللاترال اي برايم ده ممكن ما يكونش اي برايم،
مم.
علشان كده طلع لك عليه. الفكره ان الويف اللي انت جايبها دي ممكن تكون من الايزوميك كونتراكشن، ايزوميك ريلاكسيشن،
Relaxation.
بتبقى ليها بوزيتيف ونيجاتيف. محتاج ان انت كنت تاخد فريمز اكتر او تقلل السويب عشان تشوف ايه اللي ماشي مع البي ويف. ده من ضمن الليميتيشنز بتاعت التيشو دوبلر، ان الويفز بتبقى صعب تو ايدنتيفاي، وده اللي وقف التيشو دوبلر في حاجات كتير قوي يعني هي مش مشكله من الاوبريتور، هي مشكله في التيشو دوبلر نفسه، ان ساعات الويفز ما بتبقاش انت عارف انهي ويف انهي.
As for the apical 5 chamber, we could see a trivial aortic regurgitation. This is the jet of the aortic regurg. Pressure of time, it's 950 milliseconds. And the forward flow, it shows no significant gradient. The mean pressure gradient was 9. Here we moved on to the apical two-chamber view. We can see the coronary sinus related to the posterior mitral valve leaflet. And we can see here the left atrial appendage with its characteristic finger-like appearance. This is the mitral regurgitation. We proceeded on to calculate the Simpson for the patient, as we had an impression that her function might be in the fair zone. It came out with a 54%. Dimensions are dilated, yes. Now the dimensions are dilated. Dilated. The LVN diastolic was 59, and the LVN systolic was 45. It will come on later. Oh, لا, it's not index. This is the reading without index. لا, انا كنت بتكلم على الدايمنشنز مش الفوليومز. انا قصدي دايما من index. And this is the apical 3 chamber view. You could see also the aortic regurgitation, the trivial aortic regurgitation, and the mild mitral regurgitation. Here we try to focus on the RV. It shows only also a mild tricuspid regurgitation. And its dimensions are in the upper normal zone. With the preserved function, the S prime was 11 centimeter per second, and the fractional area change was 46%. The RVSP, although it's not accurate in the presence of pulmonary stenosis, but it was only 35 millimeter mercury. Here we have a modified view in the apical chamber view, where we open the right atrium. We can see that the appendage of the right atrium seems to be finger-like as well, and this made us think that we may be having two left atria, and not a right atrium and a left atrium. And this later on might suggest the presence of left isomerism for the interrupted IVC, and the presence of the appendages both seem finger-like, denoting both left atria. The apical 3 chamber modified except posterior عشان نفتح right atrium. And this is the opening of the coronary sinus, and this is the appendage of the right atrium. This is the tricuspid regurgitation. This is the parasternal long axis view. We can see here that if we go for the inflow, we can open the coronary sinus into the right atrium. Also here we can see that the coronary sinus is more related to the AV groove, and so it is more related to the AV valve, the mitral valve. However, the aorta is more posterior and it's deeper. So this is not the site of the aorta. The aorta is outside of the heart, so it would be more posterior here, like this one, and deeper, sorry, and it's more posterior. The coronary sinus is more related to the mitral valve annulus. We have only the trivial aortic regurgitation. This is the M mode for the aorta left atrium. So we have a dilated left atrium. Sorry, the dimensions are معكوسين. The left atrium is 45 millimeter and the aorta is 27 millimeter. These are the dimensions that I mentioned earlier. She has the LV diastolic is 59 and the end systolic is 43. The M mode function is 51%. However, when we did the biplane Simpson, it was 54%.
دلوقتي ما عندكش تفسير الكلام ده، يعني هو ليه الدايمنشنز دايليتد، ليه الفانكشنز فير، ما عندكش تفسير. يعني انت المايلد اورتيك ريجيرج، المايلد مايترال ريجيرج، دول ما يعملوش فوليوم اوفرلود
بالظبط،
وما فيش شنط تفسر الفوليوم اوفرلود تعمل لك المشكله دي لغايه دلوقتي.
بالظبط كده. The only thing we have is a dilated coronary sinus. This is the short axis. We used it to screen for any ventricular septal defect, but there was no VSDs. And this is at the level of the great vessels. As we can see, we have an intact interventricular septum.
سكريننج في شورت اكسس ان انت بتعمل سكريننج للسبتم كله من السب، يعني من السب اورتك او من الانلت لغايه الاوتلت، ما يبقاش عندك اي ديفكت او اي كلر معدي من الانلت.
عشان يعني to find the cause for the dilated left side. This is the pulmonary valve, the main pulmonary artery, and the RPA and the LPA. We can see a flow acceleration across the pulmonary valve. The picture is not identifying the leaflets, however, they were thickened and doomed, and we have a trivial or mild pulmonary regurgitation. So the peak gradient was 31. This puts us in the beginning of the moderate zone. So we have moderate pulmonary stenosis, and the mean pulmonary artery pressure was 15. So she doesn't seem to have a pulmonary hypertension. So now we had to move on to the suprasternal view. We won't be able to no. Approximately. طبعا the mean pulmonary artery pressure is best calculated by the hemodynamics. يعني in this case we don't have an IVC to know the pressure, the load to approximate a measurement. So we had to move on to the suprasternal view. I'll give a quick hint on how to get the suprasternal view. We ask the patient to extend his neck and look to the left side, and we put our probe in the suprasternal notch with the knob directed towards the 1 o'clock or 2 o'clock. We have two views from the suprasternal view. The first one is the longitudinal axis, where we can see the ascending aorta and the beginning of the descending thoracic aorta with its three branches, the innominate artery, the left. And in the middle, we have the right pulmonary artery. So in our patient, we can see that we have a laminar flow in the descending thoracic aorta. This signifies the absence of any coarctation. If we angulate our knob or our probe 90 degrees, we can see the suprasternal, but the short axis view, what is referred to as the crab view. We'll find that here we can see the SVC, and this is the right pulmonary artery. This is the left atrium with its 4 pulmonary veins, and this is the aorta, cross-section of the aorta. In our patient, we can see the right SVC. It's to the right of the aorta. This is the RPA. Of course, in the adults, it's a bit difficult to see the pulmonary veins as the diagram. However, in the pediatric population, we can see it better than this. However, we could see a venous structure to the left of the aorta. And this made us believe that there is a persistent left SVC. So this is the aorta and this is the RPA, and here we can see a venous structure. We moved on to focus more on it. We can see its flow to the left side of the aorta. And this is the most common reason, the most common congenital reason for the dilated coronary sinus. So we'll start our discussion with okay, so in this patient we have, she has a sinusitis, however, there's an interrupted IVC. We have dilated dimensions of the LV with fair function. We have a dilated coronary sinus with a persistent left SVC. There's only mild mitral regurgitation and mild tricuspid regurgitation and trivial aortic regurgitation, as well as moderate pulmonary stenosis. So the causes of the dilated coronary sinus can be congenital or acquired. For the congenital causes, we have a persistent left SVC. This is the most common congenital cause. The partial or total anomalous venous drainage are a second cause, and the anomalous venous drainage, if present, can say why the left ventricle is dilated. So that's why we refer the patient for a multi-slice CT. And the unroofed coronary sinus or the coronary sinus type ASD. For the acquired causes, it's mainly the elevated right atrial pressure, the presence of pulmonary hypertension, or significant tricuspid regurgitation, which were absent in this patient.
الحجم اللي انت شايفه ان هو باين في الابيكال 4 وفي الابيكال 2 في كل حته، كانه في سبتم جوه الليفت اتريوم او في حاجه تانية جوه الليفت اتريوم. ده ما بيبقاش عاده، يعني مش بنشوف كومنلي في العيانين اللي عندهم pulmonary hypertension ولا في العيانين اللي عندهم tricuspid regurgitation. ده هيخليك تتوجه لناحيه الكونجنتال كوزز اكتر. السؤال بقى، هل انت لو انت عيان ما عندوش dilated right side ولا شفت او شكيت ان عنده persistent left SVC، هتكتفي بالايكو ولا هتعمل انفستيجيشن تانية؟
لو مجرد persistent left SVC واحنا في الايكو شايفين ان هو فاتح في سوري، لو هو persistent left SVC وعامل dilated coronary sinus واحنا شايفين في الايكو ان dilated coronary sinus ده فاتح في الرايت اتريوم والال في ما عندناش اي سسبشن ان هو dilated غير البيشنت دي، مش هنعمل حاجه. بالظبط، ان هو ما فيش hemodynamic significance ليه. يعني احنا this patient we referred her for the multi-slice CT because of the dilated LV. Because we had a suspicion there might be something else like an anomalous, as well as the interrupted IVC, which made us suspect the isomerism. But if there is only a persistent left SVC with a dilated coronary sinus opening into the right atrium, we don't need any more investigations. So as we said, the persistent left SVC is the most common congenital cause for the dilated coronary sinus. It results from when the left superior cardinal vein persists, and this is the embryological origin. And it's only present in 0.4% of the general population, but up to 10% in patients with congenital heart disease. So how do we diagnose the persistent left SVC and the dilated coronary sinus? A dilated coronary sinus more than 1 centimeter in the echo is a key finding. We can use the contrast saline or the bubble test injected in the left arm to confirm its left to right flow. Of course, the CT angiography is the best for the anatomic delineation of venous structures, and we can use a cardiac MRI to provide functional and anatomical assessment. These are the presentations for the dilated coronary sinus. The most common presentation is asymptomatic, unless there are other cardiac anomalies. Its diagnosis is important for the procedures, central venous catheterization or pacemaker lead placement, especially the CRT, because of the anomalies of the coronary sinus. And if it is draining into the left atrium, it can increase the risk of paradoxical embolism and stroke. So for the management, as we said, if it's an isolated persistent left SVC with the right atrial drainage, there is no intervention needed. If it's draining into the left atrium, it needs surgical correction or closure for the risk of the paradoxical embolism and the stroke. And it's important to be identified preoperatively For the cardiac surgeries, pacemaker and ICD implantation, especially the CRT, and the EP studies for the AV node and coronary sinus variations. However, this patient had extra anomalies, the persistent left SVC, and the finding of as we can see here, the left atrium has a finger-like appendage. However, the right atrium has a broad-based appendage. From our study, we could see that the patient actually, both atria had the finger-like appendage of the left atrium, and this made us suspect the presence of an atrial left isomerism, as well as the absent IVC. This also goes with the left isomerism, as well as the persistent left SVC. That's why we had a suspicion that this patient might have left isomerism.
لقيت
ايه so the left isomerism, these are the findings of it. Bilateral left atria, the interrupted IVC with azygous continuation. There might be pulmonary venous anomalies or AV septal defects, and bilateral morphological left lungs, which are bilobed lungs. Thank you.
في أي حد عنده أسئلة يا جماعة؟
شكرا.